All right, so thank you everyone for joining us for the AMSSM Fellows Online Lecture Series. We are lucky enough today to have Dr. Julie Creech-Organ with us. She is about to start a new job with the National Capital Consortium in DC, working with their fellowship program there. And next, just as a reminder that this is not to replace your education that you're getting in fellowship, but to supplement it and use this as a resource for studying for boards. And then if you look in the chat, you'll notice that the lecture for next week is MRI review of the hip and the knee with Dr. Naveed Faraji. So we'll let Dr. Creech get started. And if you have questions, feel free to put questions in the chat and I can bring it up to Dr. Creech-Organ.
Hi, everyone. Thank you for having me this evening. We are going to discuss urogenital medicine in sports. So today, I have to start with the obligatory disclosure slide. So I am a member of the U.S. military. However, everything I will say this evening is just my own views, not that of the Department of Defense or the United States Air Force. No financial disclosures. And then I also like to say that I am not a urologist, nephrologist, or gynecologist, all of which would have perhaps a greater expertise in this. I'm family medicine trained, but hopefully what we review tonight is very much in the wheelhouse of primary care sports medicine. And you realize that these are things that you can both diagnose and at least initiate treatment, but many of the times actually complete the treatment for these conditions. So this is what we're going to cover today. We're going to very briefly cover genitourinary anatomy and then a slim amount of renal physiology. We're not going to go into that of electrolytes and that sort of thing, but just renal physiology as it helps you to understand our pathology in athletes. And we'll cover hematuria, proteinuria, solitary genitourinary organs, renal injuries, testicular torsion, and briefly urethral injuries, and then end with pudendal neuralgia. In the genitourinary system, we could consider rhabdomyolysis to fall under this. However, that has actually been covered twice before in this lecture series, most recently about 9 months ago. So for the purposes of time and comprehensiveness, that is not going to be covered today. So diving on into genitourinary anatomy, just highlighting the difference between the males and the females as we talk throughout today's lecture. When I refer to male, that will be XY chromosome and female will be XX. But you can see here the primary difference between the urinary systems is simply that the males do have that prostate, which is between the bladder and exiting the body, and it surrounds the urethra. The female's urethra is shorter, so it does make them more likely to have potential urinary tract infections. Similarly, just anatomy differences between males and females. But what I really wanted to highlight is this picture here, which just shows the musculoskeletal structure as it pertains to our genitourinary anatomy. So you see on the left side, the posterior view of the urinary system, and you can see that those kidneys, which are retroperitoneal in location, have a decent amount of protection from the bony ribs and spine. But what is not pictured is that they actually have a good amount of pericapsular fat and musculature that helps protect them from injury. It is important to note that in children, the relative size of the kidneys is larger compared to adults. So the relative size of the kidneys compared to their musculature and their pericapsular fat is favors the kidneys, and so they are more likely to be injured there. And then on the right side of the screen, you can just see that the female genital anatomy is primarily located deep within the pelvic bowl, and so making it less likely, though not impossible, to be injured, especially if we are having some traumas. So, renal physiology at the basics. We're going to start with looking at the functional unit of the kidney, which is the glomerular capsule or Bowman's capsule. And so this is fed by an afferent arteriole, or blood enters. It then moves in through the glomerulus and out through the efferent arteriole. The kidney actually receives more blood flow per unit weight than any other organ in the body. And it responds to stress and exercise by modulating this blood flow. So during exercise, we can actually have a decrease in up to 20% of the blood flow of the kidney to the kidney, and that's because the body will shunt it to go to the musculature. As a response to this decreased blood flow, the efferent arteriole actually will constrict to help increase the filtration pressure within that glomerulus. However, this constriction of the efferent arteriole does result in a relative hypoxia of the nephron. And this hypoxia, along with a buildup of lactic acidosis that we can see with strenuous and sometimes not strenuous exercise, will actually increase the permeability of that glomerulus, and it can increase the leaking of both micro and macromolecules into the urine. These changes that we see are transient. They typically last about up to 60 minutes after the cessation of activity. And obviously that can be shorter in duration if the activity is less intense and the amount of blood flow decreased to the kidney is less intense. That's all we're going to cover for physiology, but keeping that in mind, we're going to dive into exercise-induced hematuria. So this is also known as sports hematuria, stress hematuria, or athletic pseudonephritis. And by definition, exercise-induced hematuria is an asymptomatic hematuria, either gross or microscopic, that occurs following vigorous physical activity and then resolves within 24 to 72 hours. Now, within this definition, it's important to know that hematuria, by definition, is at least 3 red blood cells per high power field. And so that if it is on the shorter end or the smaller end, that's when you would probably have that microscopic. Gross obviously appears bloody. I have an asterisk by the timeline of 24 to 72 hours because that's, of course, the assumed time to resolution, but we can see it go a little bit longer in some of our athletes, specifically our ultra marathoners. We can see that extend a couple of days beyond the 72 hours. So being mindful of that in terms of when we evaluate it, which we'll discuss in a little bit. Exercise-induced hematuria can be seen in many sports, as I alluded to. Most often it is seen in our distance runners, with approximately 25% of all distance runners having some sort of microscopic hematuria. But we can also see it in sports like swimming, boxing, football, track, and lacrosse. The etiology or the mechanism behind microscopic hematuria can be either direct, thinking about a direct blow to the abdomen or the flank causing some hematuria, or indirect, which could be because of that renal ischemia that we previously talked about that can lead to that increased glomerular permeability, but also a condition called nutcracker syndrome, which is when you have compression of the left renal vein between the aorta and the proximal portion of the superior mesenteric artery, and that can be compressed during exercise and result in some of that bacteria. Further indirect mechanisms would just be things like medications or other medical conditions, thinking of things like sickle cell, where you might have some increased blood flow and increased blood clumping, as well as some of those shearing of the blood cells, and then hemophilia or lupus, which might also be associated. The diagnosis of exercise-induced hematuria is actually a diagnosis of exclusion. So we have to rule out other causes that might be responsible for the hematuria, which is the key part in our workup, and that's what we're going to talk about next. So with anything, being a good primary care sports medicine doc, it's going to start with a good physical exam or good history and physical exam. So history-wise, we want to ask things about age of the patient. That will become important. In a couple of slides, we'll talk about why that is important. Is there any history of trauma? Because not only could that indicate that direct mechanism of the hematuria, but also is that concern that we should get some imaging and evaluate for something beyond just exercise-induced hematuria. Are there urinary symptoms that might hint at something like a urinary tract infection? In our female patients, do they have a menstrual history to where it might actually just be pseudohematuria and it might actually be secondary to menstruation? And then are there systemic symptoms where we need to be thinking globally that this is something beyond just hematuria? If you have an athlete that is able to describe the timing in which they might see the bleeding, that can be helpful. Where initiation, blood seen at the initiation of the urinary stream could be urethral bleeding. That at the end of the urinary stream could be secondary to bladder, prostate, or the posterior urethra. And then if they're able to see, of course, all of these are with gross hematuria, if they're able to see some of that blood through their whole stream, then we're thinking it might be that upper urinary tract, potentially the kidneys. further, I know that I have a lot of patients that like to describe the color of things, not just related to their urine, but the color of things that come out of their body. If they're able to describe that, then we can think about darker urine might suggest, again, that upper urinary tract. Whereas if it's more of a bright pink, bright red, we're thinking it's at the end of the urinary tract, so urethra in a male, potentially the prostate. On exam, the key vital sign that you're going to want to look at is blood pressure. Heart rate can potentially play a role, but strictly in exercise-induced hematuria, we're mainly looking at blood pressure, considering if it's elevated in cases like glomerulonephritis, or if it were to be low, and we might say potentially tachycardia, we might be concerned for a large amount of blood loss and something else. Additionally, we're going to do an exam that takes a look at the back, the flank, the abdomen, looking for any ecchymosis, any abnormalities, tenderness to palpation that might suggest trauma that perhaps the athlete was unaware of. And then the genital exam is a asterisk on all the time. Obviously, if history would suggest that that is indicated, you can go ahead and perform it, but it doesn't have to be performed routinely. And please make sure you have your appropriate chaperone. So now we're going to dive into management. We're going to follow a kind of a more simplistic, easy to understand algorithm that you would see in your actual ACSM study book. So the basics of management starts with getting that initial urinalysis that shows hematuria, gross or microscopic, and in our asymptomatic, unremarkable physical exam athlete, having them stop any form of intense or vigorous physical activity. I just have them stop it completely for 24 to 72 hours. Again, this is when you need to be mindful of what type of activity the athletes do, because if we do have some of our distance runners, especially those ultramarathoners, we might want to prolong that 72 hours a little bit longer. But then at that time, you're going to repeat the urinalysis. If that repeat urinalysis shows that the hematuria has resolved and the athlete is either female or a male less than 40 years old, you can confirm the diagnosis of sports hematuria. And that just gives the athlete the reassurance that nothing is concerning at this juncture and they can return to their sport. No additional workup is needed. Interestingly, if the hematuria does resolve on that 24 to 72 hour repeat urinalysis, but the athlete is a male greater than 40 years old, we actually need to do further evaluation to exclude etiologies of urinary tract malignancy or cancer. So that's when we're going to reach out to our urologic colleagues and consider an IVP, cystoscopy, and potentially even CT scans, that sort of thing. If on the repeat urinalysis at 24 to 72 hours, the hematuria persists, we need to evaluate for why it might be persisting. So infectious etiologies, anatomic, systemic etiologies. And that's when we're going to do additional workups to include imaging, lab work, and that sort of thing to help clue us in and decide, is this something that we can manage in our training room, or do we need to help rely on some additional friends and colleagues to help us manage that? What your athletes always want to know is when can they return to play with exercise-induced hematuria. So presuming that we have confirmed the diagnosis, they can return to play just upon resolution at that 72-hour urinalysis. It can certainly reappear with a future urinalyses, but we can at that time just again hold their activity for 72 hours and ensure that we haven't had a change in clinical status. It is also nice to reassure your athletes that there is no association with chronic sequela in exercise-induced hematuria, so they aren't at higher risk for things like kidney disease, hypertension, that sort of thing. So in a similar vein, we're going to move on to exercise-induced proteinuria. And proteinuria, by definition, is protein greater than 150 milligrams in a 24-hour period of urine. Some sources say 150 to 200, so just being mindful of that potential range. But if we get above that, that's when we would have the diagnosis of proteinuria. And it can be associated with either strenuous effort in contact and in non-contact sports, and can present much of the same way where it's just an incidental finding and we need to evaluate it. The etiologies for exercise-induced proteinuria can be fourfold. So glomerular, again, thinking about back to that physiology, if we have that increased filtration, our nephron is most likely to lose some of those macromolecules like albumin into the urine. It can be tubular in nature, and this is when we get the micromolecules that escape. And these are often missed on a urine dipstick because our dipstick only detects macromolecules to the extent of 20 to 30 milligrams per deciliter. So we could be missing some form of proteinuria. Overflow, if you think about your body's just making too much protein to resorb, then that's what overflow would be. So these would be cases like multiple myeloma, where we're having a significant amount of protein within the blood. And then post-renal, these are inflammatory type conditions. There's damage to the cells of the nephron. So thinking etiologies like urinary tract infection or trauma to that region. Like I said, with exercise-induced hematuria, we're going to start with that thorough history, making sure we understand what their exercise history is, and then do a physical exam. Things we might inquire about would be if there's any recent ingestion of nephrotoxic medications, IV drug use. Do they have comorbidities that are known to kind of affect the kidneys more readily, like diabetes, lupus, hepatitis, knowing that active hepatitis is what we're concerned about, not history of and resolution of prior. Is there any recent activity, and what is the duration and intensity of that activity? And then again, physical exam is going to be much of the same as it was for our exercise-induced hematuria, looking at the blood pressure, doing that abdomen and flank exam. But the other thing we want to make sure with proteinuria is that we do evaluate for edema. Most commonly, we're going to want to look in the lower extremities, but you could also look in the face. Periorbital region often gives a good clue. And sometimes if we aren't familiar with the day-to-day appearance of some of our athletes, it might be helpful to ask them if they feel like their facial features look more swollen or if they have greater swelling. Moving on to kind of how we manage this, it's going to be very similar. So we're going to hold them out from strenuous activity for that 24 to 48 hours, repeat that urinalysis, and if it's no protein on the repeat urinalysis, again, we've confirmed, exercise-induced proteinuria. If, however, we have continued proteinuria on what we would call a standing urinalysis, because that's most likely how we are collecting these urinalyses, then we need to actually repeat the urinalysis in both a standing and a supine form. If on that supine urinalysis there's no protein, even if protein persists in the standing urinalysis, then we would have the diagnosis of orthostatic proteinuria, and we're still quite reassured in those pictures. If, however, both the standing and the supine urinalysis show that there is protein in the urine, then we need to do an additional. So you can see the labs that you can grab here. But basically what we're looking for is either, is there a glomerulonephritis, in which case we might also be seeing elevations in their blood pressure, potentially some red blood cells within the urine, some hematuria as well. Or is the proteinuria so significant that we're actually looking at a nephrotic syndrome? These would be the cases that you're seeing some of that lower extremity or generalized edema. And both of these might be reasons that we need to reach out to a nephrologist. Just these are basic summary. So again, exercise-induced proteinuria, to confirm that, we hold their vigorous activity, repeat the urinalysis. If it resolves, then we've confirmed that exercise-induced proteinuria. If, however, that proteinuria persists, then we need to get that standing and the supine urinalysis and then work them up for nephrotic or nephritic syndromes. Moving onward to our solitary genitourinary organs, we're going to focus on solitary kidney and solitary testicle. So with our solitary kidney injury, it's important to reassure our athletes and potentially their parents or guardians, depending on their age, that injury to a kidney, but especially a solitary kidney, is exceptionally rare. You can see here that the incidence in sports-related traumatic kidney injury is 6.9 per 1 million people, and that being a catastrophic injury that would result in nephrectomy to a kidney is 0.4 per 1 million, so exceptionally rare. In a 5-year time frame in which the National Pediatric Trauma Registry was monitoring for pediatric traumas, they had just under 50,000 traumas observed, and 0 of those had any kidneys that were lost secondary to sports. So again, exceptionally rare, but worth knowing about, and sometimes testable on your CAQ. So when we want to think about injury risk, we're going to think about it according to sport, and there's lots of sports listed here. I like to just look at the two kind of outliers here. So red would be our highest risk, greater than 1%. And basically anything that has extreme before the name is probably a high risk. And then also horse racing and off-road cycling. Basically, you're just going to think about something where if the athlete were to fall, it's either going to be a high velocity or potentially from a height. Those are going to put you at the greatest risk. Likewise, low risk still might involve some contact or collision that the athlete might incur during sports, but it's not going to be either at a high speed, like you might see in horse racing, or from a height. So you can see the low risk on that far right of the screen, less than 0.1% risk of injury. The key, as with many things nowadays, is going to be that you're going to use shared decision making and to discuss the risks and benefits with either the athlete alone, if they are over 18, or the athlete and the parent, and give a qualified yes. Let's make sure that they know. However, these might be athletes that you don't clear to go do extreme snowboarding. Think about some different sports for them, and then you can always talk with them about the option of protective equipment. You see pictured here would be a cartoon picture of a flak jacket. These are often worn by athletes for additional protection. Again, citing back to how the kidneys look with those ribs posteriorly, they do have some degree of exposure. It's just important to note that there is not any evidence that flak jackets actually decrease the risk of renal injury. And sometimes when we give our athletes a little bit more protection, they make riskier decisions. So just making sure that we discuss it with the athlete, knowing that there's not any true evidence that it will decrease that incidence of injury. Moving on to solitary testicle. Again, higher risk for injury when we're in our contact and our collision sports, but overall the risk is relatively low. And it actually doesn't change whether it's with dynamic or static sports. But I think the big difference in counseling here is a lot of times the impact of potential injury and loss of testicle isn't fully understood by the athlete or the parent or guardian, because the potential is kind of far out in the future of the loss of fertility. So I always like to foot stomp that with the family, that it might not be something that the athlete considers a big deal at the time, but in the future it might kind of affect what they would like to have as their family. So it is worth recommending the use of a protective cup. The American Academy of Pediatrics actually supports unrestricted participation, but in athletes with a single testicle, but does encourage protective gear. And interestingly, the National Operating Committee on the Standards of Athletic Equipment, or NOPSI, provides no recommendation for use of protective gear in solitary testicle. But again, use your shared decision making and encourage the use of protective equipment when applicable. Similarly, on the trauma route, we're going to dive into renal trauma. It's a bit more nuanced, but hopefully we can explain it in a more simplistic way. When you think about renal injury, again, it can be due to a blow to the flank, trauma to the flank, and potentially even trauma elsewhere on the body, resulting in that CAQ counter-CAQ mechanism that causes the kidney to hit the supporting structures and cause damage. The difference with presentation for renal injury compared to that of exercise-induced hematuria is that renal injury is going to present with hematuria and flank pain. So it's that blood in the urine with symptoms. So as opposed to the exercise-induced hematuria, which was asymptomatic. They may also have ecchymosis and tenderness to palpation over the flank or over the abdomen. And in severe cases of renal injury, we can see cases of hypovolemia and shock. So again, that's why when we talked about the exercise-induced hematuria, we wanted to pay attention to the blood pressure on our physical exam, because if we are noticing hypotension, we might be considering renal injury in addition to that hematuria. The diagnosis of renal injury, gold standard is to get a CT with contrast. You can consider getting a KUB, an IV pyelogram, or catheter angiography. Catheter angiography is actually the preferred mode of imaging if we are concerned that the vasculature is disrupted, but we need to make sure that they are stable. If they're unstable, consult your urologist prior to getting that study, because they might just take them back in a more emergent method. Also, get your labs, renal function panel, CBC, urinalysis. The CBC becomes important with monitoring to see if there is any significant drop in that hemoglobin. And then some other labs that you can consider. However, in a true trauma case, we might not grab those. Important to know that if you have a high clinical suspicion for renal injury and they have a normal urinalysis, you do want to go ahead and get that CT contrast, because though small, about 5% of patients It is possible to have that normal urinalysis without hematuria, but still have a renal picturing. This busy chart here is from the American Association of Surgery for Trauma, and it breaks down the 5 grades of renal injury. I've tried to compress it and consolidate it as much as possible for what we need to know. So like all grading system, grade 1 to grade 5 progresses in its severity. I think it's important just to think of grade 1 being that contusion, and then we get our lacerations that increase in size. So grade 2 would be that laceration that's superficial, less than 1 centimeter in depth. Grade 3, we bump up to greater than 1 centimeter in depth. When you get to grade 4, we have a laceration that not only goes through the cortex, but also into the medulla and collection system. And then grade 5 is basically devastation of the kidney. We have avulsion of the vascular pedicle. It's a urologic emergency. When we think about the furthest right part of the chart, the treatment and return to play, when your grades 1 through grade 4 are all going to require observation. And then you'll note that they also have some repeat urinalysis. Most of the time, you'll also repeat a CBC just to look for progressive anemia that might suggest the bleed is worsening. And then when we think about this red line, that'll help tell you if you're considering something like surgery. So grades 1 through 3, repeat the urinalysis, do observation, but unlikely to be surgery. Grades 4, grade 5 may require surgery, though it's important to know grade 4, your urologist will actually delay surgery or try to avoid surgery as much as possible, because ultimately athletes have better prognosis when we manage non-surgically. So they'll try to do that if possible. The treatment and return to play timelines are loose, though we hope grade 1 can return to play at 2 to 3 weeks. It can sometimes be prolonged as much as 6 weeks. And so just bearing in mind that when you're counseling your athlete, that it might be quite a prolonged amount of time. And regardless of the grade of injury, we do actually want to use our urologic colleagues to help us talk with athletes and determine when return to play is indicated. And that's for the American Association of Surgical Trauma. Moving on to trauma of the testicle. So we're going to talk about testicular torsion and testicular rupture. Testicular torsion, I would say, is probably a more likely topic to be have a question on the CAQ, because there are some pretty key things that we want to remember in a specific amount of time. So testicular torsion can occur from blood trauma, but it can also occur via non-contact mechanisms such as a fall. Typically, it presents with delayed onset unilateral scrotal pain that is severe in nature. On exam, we might have that swollen, firm, and tender testicle that often can have what's called as the bell-clapper deformity, which is that asymmetric high-riding testicle. And sometimes we can have a loss of the cremasteric reflex. We used to think that loss of cremasteric reflex was a little bit more reliable in confirming the diagnosis of testicular torsion. However, we're finding that we can still have torsions without that loss of reflex. So do not hang your hat on its presence or absence in this condition. Diagnosis is confirmed with our friendly ultrasound. We want to make sure that we're getting that Doppler ultrasound to evaluate for blood flow, because in testicular torsion, the reason it's a big deal is that spermatic cord actually twists on itself, most commonly twisting from a lateral to a medial or closing the book direction. And so we want to evaluate to see if there is any blood flow to the testicle. However, though our gold standard of diagnosis is Doppler ultrasound, if you have high suspicion, do not wait to begin consulting your surgeon and actually doing a surgical intervention, because as we know, time is testes. So the treatment for testicular torsion is orthopexy, regardless of whether or not you're able to manually detors or manually reduce the testicle. So because we typically see that lateral to medial rotation of the testes, we like to describe the opening the book mechanism of detorsing from a medial to a lateral motion. And if that's successful, great. But you still need to have that athlete go on to surgery to actually track down that testes within the surrounding structure. So time is critical, because we can have a 90% salvage rate if we're able to get that athlete to surgery within 6 hours. But you can see as we increase For every time that we double, we lose the likelihood that we're able to save the testes. So at 12 hours, we have a 50% salvage rate, and then 24 hours, we only have a 10%. So we definitely want to act fast and have high clinical suspicion in both contact and non-contact unilateral. Contrasting that to testicular rupture, these are rare injuries and typically presents with immediate pain and almost always is associated with trauma. I did not read a case that would be a traumatic non-contact testicular rupture. We also diagnose this with ultrasound, and once again, is a surgical emergency. However, interestingly, with testicular rupture, we actually have a little bit longer time before we would potentially have loss of the testis. So up to 90% salvage rate if done within 72 hours. So it doesn't mean act more slowly in this, but just know that the stats of salvage are a little bit more lenient with the rupture. Final on our trauma journey, we're just going to briefly touch on urethral trauma. Urethral trauma can be either to the anterior or posterior urethra. Most often is, again, secondary to blunt trauma. When we think about anterior urethral injury, it's most likely going to be because of like a straddle type injury, whereas our posterior injuries are usually associated with pelvic fracture. So in that, we might be more likely to see these in some of our higher risk sports that we highlighted earlier. So those extreme skiing, extreme snowboarding, horse racing, those types of things where we might have a higher instance of pelvic fracture. The classic triad for presentation of urethral trauma is going to be blood at the urethral meatus, some soft tissue swelling, and then the inability to urinate. In our male patients, we might have a potential of seeing a high riding prostate, but again, that's only 2% sensitive, not necessarily something that A, we're going to do readily depending upon where we're doing this assessment, and B, not something that its absence reassures you that they don't have urethral trauma. Diagnosis is going to be with imaging. You're going to be more likely to diagnose an anterior urethral injury with a retrograde urethrogram. And if we do have blood at the urethral meatus, you want to actually perform that retrograde urethrogram prior to any Foley treatment. Pictured here on the left side of the screen is just two of those urethograms, and you can actually see in both you have that contrast dye being injected, and then it's extravasation out of the urethra. So there's actually damage to the urethra in both of these pictures. Other indications to perform a retrograde urethrogram would be if you suspect that there might be a bladder injury as well. This will help you identify that. And then again, if we're concerned, it's our gold standard. So thankfully, we've made it out of our trauma series for the GU system, and now we're going to finish up with some pudendal neuralgia. So the pudendal nerve derives from the sacral plexus. It's made up of nerves from S2, S3, and S4, pictured here in green. And it supplies the sensory innervation to the genitalia, both males and females, as well as the perineum. Motor-wise, it can innervate the pelvic muscles, external urethral sphincter, and the external anal sphincter. So you can see that it has widespread innervation and can present in many different ways. Most often, though, it's going to present in our cyclists, so it's also known as bicycle seat neuropathy, and that's because of the compression that we would see there. And it's actually seen in nearly 10% of our cyclists. Risk factors are associated with thinking about just more time in the saddle or more pressure. So our athletes with increased body mass, the older age that they may be, and this is most likely because the compression, potentially they might have some loss of protective tissue, so some musculature in that region that might make the compression more likely. And then our cyclists that are spending more time in the saddle. So generally considered greater than 3 hours of cycling per week and greater than 10 years of cycling total. When in combination, those two factors exponentially increase the likelihood of pudendal neuralgia. So we talked about the pressure being the likely culprit for causing pudendal neuralgia, and its symptoms being genital numbness and pain. Sometimes in our male athletes, we can have priapism, or interestingly, we can have the difficulty either obtaining or maintaining an erection. So it can present both ways. And then we can also have some frequent urination, and that would just be because, again, of the sphincter control that the pudendal nerve plays. We can have the inability to fully release that bladder, or just it's kind of having some more overflow types. Our sites of compression are primarily threefold. So we can see it's proximally between the sacrospinal and sacrotuberous ligaments. This is more likely seen in our athletes who are stretching a lot in their motion of pedaling. You can see it in the pudendal or Alcock's canal, and that is because most likely we have too much friction or saddle pressure. And then the final place would be kind of the distal most region would be in the anterior portion of the pelvic ring. And this is most likely because of soft tissue compression. And we're thinking here about that compression on the actual nose of the saddle. So thinking perhaps that cyclist is leaning forward too much, or their saddle is actually tilted backwards. The treatment of pudendal neuralgia is, surprise, surprise, avoid the aggravating activity. So most of the time we're going to have our athletes stop cycling. They should not just wait until it starts to improve, and sometimes they need to wait until it resolves completely. So generally this is between 3 to 10 days. It depends on how long they've been experiencing symptoms and how many locations they maybe have compression, but we want to wait for complete resolution. And then in our cyclists, if that is the etiology, you want to, when they return back to cycling, you want to encourage them to get out of the saddle for about 20 to 30 seconds every 10 minutes, just to relieve some of that compression on the nerve. And then most importantly, I would say, is make sure that they have that bike fit, so that way they can avoid that stretching motion of the pedal, the potential hot spots of compression if their seat is tilted or angulated in a way that is encouraging compression of the pudendal nerve. It is important to note that though often touted and certainly sometimes fun to have a new bicycle seat, the bicycle seats that have the central cutout do not actually have any benefit in truly decreasing the likelihood of obtaining pudendal neuralgia. So making sure that you just don't have a seat that is too high, too narrow, tilted one way or another will just be the best option, but keeping your standard cycling seat is key. All right. So since we have a little bit of time, we're going to go ahead and Andy's going to help. We're going to go ahead and do just 3 basic questions just to see if we've learned anything. So question 1, we have a 47-year-old recreational marathoner. This is a male patient who has presented to your clinic after he attended a health fair at work where they did a screening urinalysis and found microscopic hematuria. He reports that he feels well without dysuria or other symptoms. In clinic, his blood pressure is 120/80, and he has an unremarkable physical exam. You could do a repeat urinalysis, and it is without any hematuria. So what is the next step in management of this patient? Sorry, I went forward, so I hope everyone responded, but yes, the answer is D. Good, okay, so we made it about a third for our answers. So going through this, we're actually gonna so reassurance and return to sport would be the right answer if this athlete were less than 40. But remember, if we forward here, because our athlete is a male who is greater than 40 years old, he actually needs to be evaluated for urinary tract malignancy. When we repeat the urinalysis in 72 hours, this would be something that is not unreasonable because he's a recreational marathon runner. So if we're thinking about those ultra marathon runners, we know that 72 hours might not actually encompass the true time to resolution. So that would be a possibility. But the most right answer is B, that we want to refer him for cystoscopy and evaluation for that urologic malignancy. Okay. Now moving on to question 2. Move this out of the way. We have a 14-year-old female who presents to your clinic for her pre-participation physical exam, and she's with her mom. She has a past medical history for menarche at age 12 and a solitary kidney that she had since birth. Which of the following sports poses the greatest risk for renal injury? They have soccer, cycling, skiing, and skateboarding. All right, so close between skiing and cycling. We will move forward to here, just remembering racket tennis, cycling. And again, if we're just thinking, though skiing has a high risk, an elevated risk compared to our low risk sports, it is in that moderate risk category. And so cycling has a high risk. It is not one of these extreme ones. I couldn't give you extreme skiing because that's a little too easy. But just remembering this table in terms of what our higher and lower risk sports are. All right, we'll finish off with one more question. Question 3, we have a 25-year-old male. He's a competitive cyclist who presents to the clinic with concerns of perineal numbness and difficulty maintaining erections. Which of the following is the origin of the nerve most likely responsible for his symptoms? Wonderful. So 100% of you guys got it right. The pudendal nerve, which is from S2 to S4, pictured here as we highlighted. And so, yes, cycling and pudendal nerve go hand in hand in terms of most likely sport to cause it. So good job. All right, finishing up, these are just the key takeaways. So remember, the definition of exercise-induced hematuria is that asymptomatic hematuria, which again is greater than or equal to 3 red blood cells per high power field, that resolves with avoidance of vigorous activity, typically 24 to 72 hours. Risk for injury in solitary testicle is increased in contact sports, so you need to counsel on the infertility risk. Remember, the renal trauma and renal injury grades 1 through grades 3 are managed in a non-operative fashion. However, we do need to do observation, CBCs, urinalysis, and a CT scan if stable. And especially the stability when we're looking at potentially grades 4 and grades 5. And then testicular torsion is typically that severe but delayed unilateral testicle pain with that Bell-Klopper deformity, so potentially high riding testicle. We can attempt manual reduction by opening the book, but ultimately we need emergent surgical evaluation, and orthopexy is the treatment regardless of whether or not that detorsion is successful. And then these are all of my sources.
Thank you. That was wonderful. I know I definitely learned a lot, and I will use this when I go back and study for my recertification. I feel like you definitely presented it in like a very simplistic manner for us to understand. So thank you for that. If anyone has any questions, please feel free to type them in the chat, or you're welcome to speak up to ask your questions as well. So it looks like no one's asking any questions. There was a chat message just saying no questions, but it was a great lecture. So again, thank you so much for this. It's very relevant as something we may see on the sidelines in the clinic and definitely on board. So thank you. And if anyone does have future questions for Dr. Creech-Organ, I'm sure she's happy to have you reach out as well. Thank you so much.